This is the audio lecture for Chapter 16, Nursing Care of the Family During Labor and Birth. For most women, labor begins with the first uterine contraction, continues with hours of hard work during cervical dilation and birth, and ends as the woman and her family begin the attachment process with the newborn. Nursing care management focuses on assessment and support of the woman and her significant others throughout labor and birth, with the goal of ensuring the best possible outcome for all that are involved. The first stage of labor begins with the onset of regular uterine contraction and ends with complete cervical effacement and dilation. As you may remember from previous lectures, the first stage of labor consists of 3 phases. Those phases are the latent phase or early, the active phase, and the transition phase. During the latent phase, the contractions are usually kind of mild to moderate. The cervical dilation is usually 0 to 3 centimeters. During the active phase, the cervical dilation is 4 to 7 centimeters. And the transition phase of the first stage of labor begins when the cervix reaches 8 to 10 centimeters of dilation. Care management during the first stage of labor. Most nulliparous women seek admission to the hospital in the latent phase because they have not experienced labor before and are unsure of the right time to come to the hospital. Multiparous women usually do not come to the hospital until they are in the active phase. Even though no two labors are identical, women who have given birth before often are less anxious about the process unless their previous experience has been negative. Now, the determination of true or false labor. Remember my definition of true labor. There's progressive cervical dilation or effacement with uterine contractions that are becoming more frequent. Their intensity is getting a little harder and the duration is lasting longer. So, true labor, they're having regular contractions, they're increasing in intensity, frequency, and duration, plus is causing cervical change. The cervix is either going to dilate more or there's going to be more effacement. So determining true or false labor is up to the perinatal nurse, and typically what we do, we have the women come in, or if they present to the hospital, typically we'll put them on a monitor, look and see how the tracing is. We'll check their cervix and see if they're dilated any. Then usually if they're not dilated or they're still in that early phase, we'll let them walk for an hour or two to see if the contractions either pick up or if they kind of dwindle out. Once they've done walking for an hour or two, we'll bring them back in, put them back on the monitor to see if the contractions are indeed increasing in frequency, and then we'll recheck their cervix to see if there's any cervical change. If they've made cervical change, typically we will admit them to the labor and delivery suites, or if their cervix has not changed and the contractions have kind of spaced apart, we usually will send them home, but we will send them home with some type of relaxant, maybe like a Vistaril or something to just kind of help relax them so they can get a good night's rest, and then see if the labor picks back up again. This is figure 16-1 in your textbook, and it's just showing the admitting process. You can see the nurse here is doing her admission paperwork for the pregnant patient. EMTALA, the Emergency Medical Treatment in Active Labor Act, is a federal regulation enacted to ensure that a woman gets emergency treatment or active labor care whenever such treatment is sought. According to the EMTALA, true labor is considered to be an emergency medical condition. Nurses working in labor and birth units must be familiar with their responsibilities according to the EMTALA regulations, which include providing services to pregnant women when they experience an urgent pregnancy problem and fully documenting all the relevant information. A pregnant woman presenting in an obstetric triage is considered to be in true labor until a qualified healthcare provider certifies that she is not. Agencies need to have specific policies and procedures in place so compliance with EMTALA regulations is achieved while safe and efficient care is provided. Now, EMTALA came about, and this is something I experienced firsthand while working in labor and delivery. Since I worked at the city hospital, anyone who came in for any type of labor issue, pregnancy issue, we had to treat them because we were the city hospital. Now, if a patient without insurance or who didn't have any prenatal care, if they went to maybe a private hospital, what that private hospital would do without really even examining the patient, they would put them in an ambulance and send them to the city hospital where I worked. So we had a lot of problems with, premature babies maybe being born en route to the hospital, or even full term babies being born while en route to the hospital. So this, and I know it was happening probably nationwide because, the private hospitals, they didn't want to not get reimbursed for the services they provided. So they would send anyone who came to the private hospital who was pregnant and didn't have insurance, they would send them over to the city hospital where they knew we would have to take care of that person. That way their hospital wasn't losing any money. And like I said, if it was happening locally here in Florida, I know the problem was nationwide. So the federal government stepped in and said that wherever the pregnant woman goes, they have to be treated. If they think they're in labor, they have to be ruled out. You can't just send them to another hospital. They would have to be seen by a physician, midwife, anyone, at that hospital who specialize in OB care. All right, we're still talking within the first stage of labor. Now we're doing the assessment and nursing diagnosis. Now we've had a patient who came into triage. We now know that yes, she is indeed in labor. So what happens next? So this is when the admission process begins. Typically, we will move the woman if she's been seen in triage. We would move her over to the labor and delivery unit. We will get her prenatal data. Usually it's always good to have prenatal records from their office visits, and usually if they haven't been provided to the hospital already, you'll see the nurse call the doctor's office and ask for the patient's prenatal records to be faxed over. We then interview the woman. We start asking her all the pertinent questions. What's your due date? Did your water break? You've been leaking any fluid? Any bleeding? How's the pain? Are you feeling the baby move? We always ask moms the questions to rule out pregnancy-induced hypertension, such as, are you seeing spots? Do you have blurred vision? Do you have problems with headaches? How is your edema, your swelling? Are you having pain, epigastric pain under your right breast in the area of the liver? So these are all the things we ask the mom. We ask about the significant other, family history. This is when the nurse gets deep down and dirty in the mama's business. Me, as the perinatal nurse, I want to know everything. I want to know who's with the mom. Is this the father? Is this the significant other? Is this the boyfriend and the husband doesn't know about it? There's all kind of psychosocial dynamics that come up in labor and delivery, and the girls who just did their OB rotation with me, they got to experience some of these things. I think the police or either security had to come up and escort people out of the room. So definitely we're looking at psychosocial factors. Is this a planned pregnancy? Is this an unplanned pregnancy? Is this the pregnancy because of a rape or molestation? Any of those things. We're looking at the stress in labor. We already know labor is painful, it's already stressful, but are there any additional stressors that the mom may be dealing with? And definitely, we have to always ask if there are any cultural or even religious factors that we may need to know about. Some of the cultural things, I know some cultures, the man isn't in the room, they're usually in the waiting room. Or I've had men who stood outside the delivery room. They wouldn't go in, they would have either the sister or the mother or the mother-in-law, because it was the woman's responsibility to help the pregnant mom through labor. So there's all different type of cultural, religious factors. I know some of the Muslims I've delivered, it had to be absolutely quiet in the room at the time of delivery, and typically it was the father was the first voice the baby had to hear, and the father would do maybe like a little prayer. He would whisper it in the baby's ear. So there's so many cultural factors that we need to be aware of, and the easiest way to find out is to ask. So that's why I say this is the time for the nurse to really get no, not nosy, but get in there and see what the woman wants, what the family is looking for. What can we do as the nurses to make this a positive experience for that mother and the family? This is figure 16-2 in your textbook. It's the admission screens in an electronic medical record. A shows the general admission screen, and B shows the current admission screen. This is figure 16-3 in your book. This is a birthing room specific to Native American population. As you can note, the arrow pointing east, the rug on the wall, and a rope sash or belt hanging from the ceiling. So these are some of the cultural things that I was talking about. I've you may not see this here in the South, but I'm sure in parts where Native Americans, there are big populations, you probably will have a labor room set up specifically for that culture. Okay, the physical exam of the pregnant patient. The initial physical exam includes a general systems assessment and an assessment of fetal status. During the examination, uterine contractions are assessed and a vaginal examination is performed. The findings of the admission physical exam serves as a baseline for assessing the woman's progress from that point. The information obtained from a complete and accurate assessment during the initial exam serves as the basis for determining whether the woman should be admitted and what her ongoing care should be. On admission, the nurse should perform a brief systems assessment. This includes an assessment of the heart, lungs, and skin, and an examination to determine the presence and extent of edema of the face, hands, sacrum, and legs. It also includes testing of deep tendon reflexes and for clonus if indicated. And typically we do the DTRs and clonus if we have a mom that we suspect has pregnancy-induced hypertension, preeclampsia, any hypertensive disorders. You also want to note the woman's weight. Increasing number of women are overweight or obese. Excessive size can make nursing care during labor and birth more difficult and places the woman at risk for complications such as operative birth, infections, and blood clots. Vital signs. You want to assess the vital signs on admission. The initial values are used as the baseline for comparison for all future measurements. If the blood pressure is elevated, you want to reassess it 30 minutes later between contractions to obtain a reading after the woman has relaxed. You want to encourage the woman to lie on her side to prevent supine hypotensive syndrome and resulting fetal hypoxemia. Typically, we monitor the temperature if the water is intact every 4 hours, or if her water is broken, we usually do her blood pressure every 2 hours. And then vital signs depends on the phase of labor that she's in, and if you look in box 16-4, it gives you the nursing assessments in the first stage of labor. So it goes through when to perform the blood pressure, the pulse, the fetal heart tones. So make sure you read this box 16-4, nursing assessment in the first stage of labor. Leopold's maneuvers. These maneuvers are performed with the woman briefly lying on her back. Leopold maneuvers help identify the number of fetuses, the presenting part, the fetal lie and fetal attitude, degree of descent into the pelvis of the presenting part, and expected location of the point of maximal intensity of the fetal heart rate on the woman's abdomen. And last week, I think I had a film as part of your discussion board that showed how Leopold's maneuvers are done. And typically, it takes about 2 to 3 minutes to do Leopold's maneuver. And if you were with me in OB, you saw that before I put the woman on the monitor, I would just kind of feel around her belly to kind of see where the back of the fetus was, and that helps make it easier to find where to place the ultrasound so that we can pick up the baby's heart rate. Assessment of the fetal heart rate and pattern. Like I said, typically you find the baby's heart rate best over its back, so you want to examine the mom's stomach to kind of feel your way around and see where the back is. As your textbook said, usually in a vertex or a head down presentation, you can hear the fetal heart rate below the mother's umbilicus in either the right or the left lower quadrant of the abdomen. And in a breech presentation, where the butt's coming out first, you usually hear the fetal heart rate above the mother's umbilicus. In addition, the perinatal nurse must assess the fetal heart rate after rupture of membranes, because this is the most common time for the umbilical cord to prolapse. We also want to check the heart rate after any change in the contraction pattern or maternal status, and before and after the woman receives medication or a procedure is done. This is figure 16-4 in your textbook. It shows the nurse documenting assessment findings on a computer and a labor, delivery, recovery, postpartum room. And if you look, here's the fetal monitor, and here's the fetal heart rate tracing. Typically, most places don't print out these tracings anymore. They can see them on the computer screen and it's saved forever. Every now and again, I know when we were on antepartum, when we did a tracing, if they had a question about it, they would turn the printer on so the tracing could be printed. But typically, we look at the tracing on the computer screen. This is figure 16-5 in your textbook, and it's showing supine hypotension. Note the relationship of the gravid uterus to the ascending vena cava in a standing posture. A, and supine posture. C, compression of aorta and inferior vena cava with the woman in the supine position. And we know the best way to relieve the symptoms of supine hypotensive syndrome is to turn the mom to her side. So here, picture D is showing that the supine hypotensive syndrome is being relieved by the use of a wedge pillow placed under the woman's right side. So in labor, we don't encourage our women to lie flat or supine. We want them either semi-Fowlers or on their side, because we want to prevent supine hypotensive syndrome, because we know it makes the mom feel bad. They get weak and feel like they're going to pass out, and it also decreases perfusion to my baby, so they'll have heart rate pattern changes on the fetal monitor. This is figure 16-6 in your textbook, and it's showing the assessment of uterine contractions. Picture A shows the abdominal contour before and during the uterine contraction, and B is the wave-like pattern of contractile activity. And if you look at the contraction, you have the increment, the acme or the peak of the contraction, and then you have the decrement the contraction going away. And then right in here is your relaxation time. And then this is the beginning of your next contraction. So this is where the resting tone, you may hear me say the resting tone, that's the period of relaxation between the contractions. Assessment of uterine contractions. A general characteristic of effective labor is regular uterine activity, but uterine activity is not directly related to labor progress. Uterine contractions are the primary powers that act involuntarily to expel the fetus and the placenta from the uterus. Several methods are used to evaluate uterine contraction, including the woman's subjective description, palpation and timing of contractions by a healthcare provider, and electronic monitoring. Here's a question. What is the only way I can tell the true intensity of a woman's contraction? The answer is with the use of an IUPC or intrauterine pressure catheter. Now, when we're talking about uterine contractions, these are the terms that we use to describe the characteristics of a contraction. If you hear frequency, that is how often the uterine contraction occurs, the time that elapses from the beginning of one contraction to the beginning of the next. The intensity is the strength of a contraction at its peak. The duration is the time that elapses between the onset and the end of the contraction. So from the start to the end of the contraction, that's how long or the duration of it. And the resting tone is the tension in the uterine muscle between contractions or the relaxation of the uterus. Uterine contractions are assessed by palpation or by using an external or internal electronic monitor. The following terms, it describes what is felt on palpation. Typically, and I've said this before in class, mild is slightly tense fundus that is easy to indent with the fingertips. It feels like the fingertip of the nose. Moderate is a firm fundus that is difficult to indent with fingertips, and if you touch your chin, feels like that. And then the strong is a rigid board-like fundus that is almost impossible to indent with fingertips. And then touch your forehead, and that's what a strong contraction feels like. The vaginal examination. The vaginal exam reveals whether the woman is in true labor and enables the examiner to determine whether the membranes have ruptured or if her water bag is broken. Because this examination is often stressful and uncomfortable for the woman, perform it only when indicated by the status of the woman and her fetus. For example, perform a vaginal exam on admission, before administering medications, when significant changes has occurred in uterine activity, on maternal perception of perineal pressure or the urge to bear down, when the membranes rupture, or when you note variable decelerations of the fetal heart rate. A full explanation of the examination and support of the woman are important in reducing the stress and discomfort associated with the examination. This is figure 16-8 in your textbook. It's showing a vaginal examination. In picture A, you see an undilated, uneffaced cervix with the membranes intact, and you can see the bag of water. You can kind of see it better in your book. That's still around the baby. And then B is palpation of the sagittal suture line. You have a cervix that is effaced and partially dilated. As you can see, the woman can get at least two fingers in there. And here you can see where she can't get her finger in the cervix because it has not started to dilate. Laboratory and diagnostic tests. The first test we're going to talk about is the analysis of the urine specimen. And you know, anytime a pregnant woman comes in, we always ask her to give us a urine specimen. Typically, we do the urine specimen to see if the mom may have, if she has any infection going on. We look to see if she's spilling protein, because if we know she's spilling protein, she may be having issues with preeclampsia or eclampsia. And we usually will see if she's spilling any glucose. Maybe she's gestational diabetic, or she's a pre-gestational diabetic, and to see if there's any ketones to make sure that she is nutritionally intact, or that she's not dehydrated and things like that. So every woman who comes in will have a urine dipstick, and those who have been in the hospital with me, they have become quite proficient in the art of dipsticking urine. Blood tests that can be performed. Now, this is going to vary from hospital to hospital, but typically the most common blood test that we're going to do a CBC, because we need to look at the mom's H&H. We need to look at her platelets, her white blood cell counts, make sure she doesn't have an infection. And typically we will do a blood bank, like a type and screen, just to make sure that in case we need blood, if the mom decides to bleed or hemorrhage on us, we have a type and screen done where we can easily change that over to a type and cross and have blood waiting for her. Uh, Now, if the mom hasn't had any prenatal care, we would do more labs. We would do all the prenatal labs, the CBC, the blood type, look at her blood type, her RH status, her rubella, her HIV, her hepatitis. All of those blood tests, her RPR, which tests for syphilis. So, all of the blood work that she should have had done while she was pregnant, if they come in with no prenatal care, we do the entire prenatal package. The only lab we wouldn't be able to do is probably the GBS, because we wouldn't have the results back in time. Now, your textbook says if we don't have the GBS, they could do the rapid GBS, but typically, if they're coming in with no prenatal care and they're in true active labor, we don't have time. So, what some physicians would do, they would just err on the side of caution. If they've had no prenatal care, they would just treat the mom as if she was GBS positive. Assessment of the amniotic membranes and fluids. Labor is initiated at term by SROM, that's the spontaneous rupture of membranes, in approximately 25% of pregnant women. A lag period, rarely exceeding 24 hours, may precede the onset of labor. Membranes also can rupture spontaneously anytime during labor, but they usually rupture during the transition phase of the first stage. That's when the mom is 8 to 10 centimeters. Or we can artificially rupture the membranes, which you'll hear AROM, and that's when the practitioner, either the OBGYN or the midwife, breaks the mom's bag of water. Now, whether the membranes rupture spontaneously or we break their bag of water, you must note the time of the rupture. Other things we should document is the color and the consistency of the amniotic fluid. You're looking to see if the fluid may be meconium stained. That's when the baby takes their first poop inside the uterus. The estimated amount and the odor of the fluid. Once the bag of water breaks on its own, or if we artificially rupture it, the first thing you want to make sure is that the cord does not prolapse, where that's the cord delivers before the head comes out. And typically, the way that we kind of make sure this doesn't happen is before we break the bag of water, the practitioner wants to make sure that the fetal head, or the presenting part, is well engaged. If the baby is still palatable, that's when we check the cervix, we push up on the head, and the baby floats away. You don't want to break the water then, because there's a chance that that cord may slip out. But if the baby is well engaged when we break the water, that helps reduce the chance of a prolapse cord. So anytime the water breaks, whether it's on its own, which we call spontaneous, or if it's artificial, the one thing the nurse wants to do is make sure that there's no prolapse cord. And on the fetal heart rate tracing, what you would see is a prolonged deceleration. And we talked about that in the last lecture. Another thing that you're going to worry about once the water bag is broken is infection, because like I said, the vagina is not a sterile place. So once the bag of water is broken, that the baby loses that protective surrounding of the amniotic sac. So infection can travel up through the vagina into the uterus and cause chorioamnionitis, which is infection of the bag of water surrounding the baby. So once the bag of water is broken, like I said earlier, we check the mom's temperature at least every 2 hours. And then this is a time where we kind of take a hands-off approach. You don't want to be checking the mom's cervix every hour, every 2 hours, because we're just introducing more bacteria, which increases their risk of getting infected. So typically, once the water's broken, we kind of take a hands-off approach. And typically, if the mom says, I feel like I need to do a number two, or I feel like I need to push, then we would check the cervix, or if there's any change in the heart rate pattern or the contraction pattern. But typically, we don't want to be checking this mom very often because of the increased risk of infection. Physical care management during labor. General hygiene, basically, you want to make sure the mom is clean, is comfortable. Most labor and delivery units have showers. If the mom wants to sit in a warm shower, not only does it help with the contractions, it just helps with the overall sense of hygiene. Definitely, if the mom is using the bedpan, you want to offer the mom soap and water, or either the antibacterial soap or some wet nap so she can clean herself. Nutrient and intravenous intake. Most of our moms in labor, they're either NPO or ice chips only. Some hospitals or physicians may let the mom do like popsicles, things like that, but very rarely will you have a mom eating a full meal while she's in labor. Our IV intake, we usually have them on most places use lactated ringer. Some may use normal saline, but the fluid of choice is the lactated ringers, or LR. And usually each mom, when they come for admission, they get an IV access, and then usually IV fluids of LR that are hung. And with the culture, way the culture is now, most women are getting epidurals, and so we have to have an IV access so that we can hydrate them for the epidural also. Elimination, we still offer women, if they need to void, if they don't have an epidural, if they can get up, they can get up, go to the bathroom, or if they want to use a bedpan, they can. But for most women, after they receive their epidural, we usually place a Foley catheter in, because we want to make sure that the bladder doesn't get distended, because that can impede the descent of the fetal head into the pelvis. Ambulation and positioning. If the mom wants to ambulate, if she doesn't have an epidural, we do like the moms to ambulate, because like I said, the more they ambulate, the more they change position, the more my baby rotates in the uterus, so that they can get in that great OA, or occiput anterior position, so that they can deliver a little bit easier. So we definitely We want the moms to ambulate if they can, if they don't have an epidural, and change their positions frequently. And if they have an epidural, we change their positions for them. Usually, about every 30 minutes or so, we'll turn them side to side, semi fowlers. Just the more you can position the mom, the more you get that baby to rotate and get into the correct position for delivery. These are just pictures that are in your textbook. This shows the mom standing and leaning on her support person. And then this is a mom who's on her hands and knees and her support person giving her sacral pressure. Here's a mom who's squatting on the side of the bed. And you can also, if we can make the bed, transform it into any shape we want, and you can actually put the mom in a squatting position while she's sitting on the bed. And this is a mom who's a sideline position with her support person there, and then someone giving her a back rub or sacral pressure. Here's a mom on a birthing ball, and you can see the person there is trying to listen to like the fetal heart tones there. Most hospitals should have a birthing ball somewhere, but a lot of women, they bring their birthing balls with them. Um, I'm kind of on the sideline of the birthing balls. We used to practice with them in labor and delivery, and to sit on that to me was not comfortable. But a lot of the pregnant women said it does help relieve the pressure on their back when they're sitting on the birthing ball. But usually I would roll and fall on the floor on it, but hey, that's me. But a lot of my moms who come in with doulas and midwives, they really like using the birthing ball. And then this is a picture of the significant other offering the laboring woman ice chips. And usually, what I would do as a nurse, because the women would beg for something to drink, and I would say, well, you can have one sip of the melted ice chips. I usually, like, that was their treat if they were handling the labor well. I give them a sip of water. But typically, we do just want ice chips. But like your book was saying, research is not proven that, having an, not having anything to eat or drink while in labor is effective, because most women, when we do surgery, they don't have general, they're awake and they can protect their airway and things like that. So we'll see what happens later on, but for the most part, we still do keep the woman ice chips. And some of my midwives, they will let them do clear liquids like apple juice, water, popsicles, things like that. Support during labor and birth involves emotional support, physical care, and comfort measures, and advice and information. The value of the continuous supportive presence of a person during labor has long been known. Women who have continuous support beginning in early labor are less likely to use pain medication or epidurals. They're more likely to have a spontaneous vaginal birth and less likely to report dissatisfaction with their birth experience. No harmful effects from good continuous labor support have been identified. To the contrary, there is good evidence that labor support improves important health outcomes. So those people that can help provide support while the woman is in labor includes the nurse, the father or the partner of the pregnant woman, doulas, which are your birth assistants, birth attendants, grandparents, if they have midwives. Typically, midwives stay around and stay in the room a little bit more with the patients. Uh, Grandparents, siblings. There's all kind of people who can be support for the patient. Siblings during labor and birth. Now, this is a very heated topic in some labor and delivery area, because a lot of people just don't see the value of having maybe a younger child during the delivery. Um, I've had some where, like, the moms would bring their teenage daughters in to say, this is what labor's like. You don't want to experience this, so don't get pregnant. And then sometimes I've had women who've had like younger children, like 3, 4, 5 years old, in the labor room. And basically, you know, I kind of would judge it on how the child would act. If I saw that the child was just like upset seeing the mom in pain and crying, I would ask the mom, do you still really want the child in here to see this process? um, but a lot of times when the moms would bring their younger children in, they've had gone through some type of prenatal class to help prepare the child also. So I enjoyed having uh, I like having the older children, like the teenage girls, in there with their moms, because they were like, oh my God, I never want to get pregnant again. And the mom would look and it's like, that's why you're here, because I don't want you to get pregnant. But typically, most agencies, they'll let the siblings of the pregnant mom in, but usually we didn't let anyone under the age of 12 unless they were a sibling. But that depends on the hospital. When we're talking about emergency interventions, the most normal labor can always take a change for the worse and become an emergency type situation. So the perinatal nurse is just always on the lookout for any complications that arise, and typically we have things set in place where if we need to do an emergency C-section, or if we need to do an emergency procedure, we can do it right then and there. We really don't have to wait around. And you see that a lot in your teaching facilities where they have OB residents. And in case the primary physician isn't there, we would get things started with our OB residents, and then the primary physician, would just come in and pick up when they got there. This is figure 16-14 in your textbook. The first picture shows a mom pushing. She's pushing in the sideline position. You can see the perineal bulge. And then here, B, you have the mom pushing in a semi-sitting position, and the midwife helps the mother feel the top of the fetus head. You can see the picture better in your textbook. Okay, the second stage of labor. The second stage of labor is the stage in which the infant is born. This stage begins with full cervical dilation and complete effacement, and ends with the birth of the baby. The force exerted by uterine contractions, gravity, and maternal bearing down efforts facilitates achievement of the expected outcome of a spontaneous, uncomplicated vaginal birth. The median duration of a second stage of labor is 50 to 60 minutes in nulliparous women and 20 to 30 minutes in multiparous women. The upper limits for the duration of normal second stages of labor are nulliparous women, 2 hours with no anesthesia and 3 hours with regional anesthesia. And for multiparous women, 1 hour with no anesthesia and 2 hours with regional anesthesia. The second stage of labor is composed of two phases, the latent phase and the active pushing or descent phase. The latent phase is a period of rest and relatively calm. During this early phase, the fetus continues to descend passively through the birth canal and rotate to an anterior position as a result of ongoing uterine contraction. The woman is quiet and often relaxes with her eyes closed between contractions. The urge to bear down is not strong, and some women do not experience it at all or only during the peak of a contraction. Delayed pushing has been shown to result in significant decrease in pushing time, significant increases in the duration of the second stage of labor, and a reduction in the number of operative vaginal births. So this is what you may hear termed laboring down. It's when the women gets to 10 centimeters, we don't automatically start pushing. We usually just let the baby do the work, let the contractions and the baby work its way down and continue to rotate and change their position to that OA position. During the phase of active pushing or descent, the woman has strong urges to bear down as the Ferguson reflex is activated when the presenting part presses on the stretched receptors of the pelvic floor. At this point, the fetal station is usually +1. So is that above or below the ischial spines? That's correct. The head is below the ischial spines and the position is anterior. This stimulation causes the release of oxytocin from the posterior pituitary gland, which provokes stronger expulsive uterine contraction. The woman becomes more focused on bearing down efforts, which become rhythmic. She changes positions frequently to find a more comfortable pushing position. The woman often announces the onset of contractions and becomes more vocal as she bears down. The urge to bear down intensifies as descent progresses and the presenting part reaches the perineum. The woman may scream or swear and may act out of control. Preparing for birth. A maternal position during the second stage of labor. There's no one set position. Usually, I let the mom choose the position that she's most comfortable in and the position that she chooses or that she pushes the best in. So, whatever makes her happy during this time, whatever makes her push more effectively, I let the mom pick her position. Bearing down efforts. Typically, if the mom does not have an epidural, she's going to feel that urge once that baby gets low into the pelvis. So she's going to tell you when she needs to push. Sometimes women who have the epidural, and especially if they have a really good epidural, they may not feel that urge to push. So sometimes we have to coach them, like, here comes a contraction, you may want to start pushing now, or let's push now. Usually we will coach the woman to hold her breath and we count for 10. This method of bearing down may trigger the Valsalva maneuver, which occurs when the woman closes her glottis, which increases intrathoracic and cardiovascular pressure. So some people, it depends on the mom, it depends on the physician. More and more you're going to see the closed glottis pushing, but every now and again we have what we call the open glottis pushing, where the mom doesn't have to take a deep breath, hold it, and count. And while we count to 10 and she pushes, the mom is pushing and she's making her sound. She's not holding her breath. I hate to do this, but I'm going to kind of describe what it sounds like. So with the open glottis, you'll hear more of the uh, we encourage them to make the noise as they push. On the other hand, the closed glottis, you're saying take a deep breath, hold it. They're holding their breath, and we're going 1, 2, 3, 4, 5. So there's a lot of controversy over which way of pushing is better. My belief is whatever gets the baby out. If the mom wants to scream, I've had moms scream the whole time, but during their screaming, the baby was still coming out, so she was pushing, so I let her do that. I've had moms who vomited the whole second stage, but you know what? It helped push the baby out. So whatever helps push the baby out, whatever's most comfortable for the mom is what I like to do. I like to tell the woman, you'll hear, listen to your body. Let your body dictate what to do. And like I said in lecture, you really don't have to push. Those babies will find their way out of the uterus and the vagina. So that's my spiel on that. The fetal heart rate pattern. Even during the second stage of labor, we must check the fetal heart rate regularly. If the baseline rate begins to slow, if absent or minimal variability occurs, or if decelerations develop, such as you're late or prolonged, we have to initiate interventions promptly. So typically, we'll turn the mom onto her side to reduce the pressure of the uterus against the vena cava. We can give oxygen. Like I said, we use a non-rebreather mask and we put it at 10 liters a minute. If those interventions don't help and the baby still continues to have an abnormal pattern, we may have to choose the operative delivery. Sometimes you'll see the physician, they may put a vacuum on the baby's head to kind of help speed up the second stage, or if the baby just decides, I am not liking this, and they have a prolonged deceleration, if it goes more than 10 minutes, we would do an emergency cesarean section. Support of the father or the partner. During the second stage, the woman still needs continuous support and coaching. So we do have the fathers there. We encourage them to participate, or we have the moms or any other family members that are there. It's always nice to have someone hold the leg for you. Supplies, instruments, and equipment. Typically, all of that stuff is on our instrument table. The labor and delivery room usually has all the supplies that we need, and usually we have everything in the room that we need in the birthing room. This photo just shows all the different positions that we can put the mama in while pushing, and like I said, this bed can almost take on any shape or any position that you can think of. And this is showing the mom pushing. We're using the stirrups, the leg stirrups, so that we don't have to hold her legs. And then we have these handlebars that come up where the mom can pull against those while she's pushing. Then this is what the delivery table looks like. You have your instruments. You better have a pair of scissors, some clamps. We have a cord clamp, the bulb syringe. Usually there's a basin there. If the physician usually will, some physicians like to have sterile water. Then these are the drapes that the physician uses to cover up the mom. So that's what the delivery table looks like. And this is a picture of the baby warmer that is set and ready to go. And typically when we start pushing, or we see that the baby's descending properly because the mom's pushing well, we'll turn the warmer on, set it so that it could be warming up for when the baby does deliver. This is a picture of an operating room suite for those moms who have to have cesarean sections or emergency C-sections. This is what the operative suite looks like. This is figure 16-20 in your textbook. It's the beginning birth with vertex presentation. And as the mom is pushing, these are signs that are showing, hey, the baby's getting closer. And then this is the baby actually crowning. So this is when you know birth is imminent. The mechanisms of birth and the vertex or head down presentation. The three phases of the spontaneous birth of a fetus in a vertex presentation are birth of the head, birth of the shoulders, and birth of the body and extremities. With voluntary bearing down efforts, the head appears at the introitus. Crowning occurs when the widest part of the head descends the vulva just before birth. Immediately before birth, the perineal musculature becomes greatly distended. If an episiotomy is necessary, it is done at this time to minimize soft damage. A local anesthetic such as lidocaine may be administered if necessary before performing the episiotomy. Immediate assessment of the care of the newborn. The care given immediately after birth focuses on assessing and stabilizing the newborn. The nurse is usually the primary person responsible for care of the infant at this time because the primary health care provider is involved with delivery of the placenta and care of the mother. The nurse must watch the infant for any signs of distress and initiate appropriate interventions. Typically, the assessment includes with assigning the APGAR scores, and we assign the APGAR scores at 1 and 5 minutes. We want to make sure that we maintain a patent airway, support the respiratory effort, and prevent cold stress by drying and covering the newborn with a warm blanket or placing him or her under a radiant warmer. Or what we could do is kangaroo care, where we put the baby skin to skin with the mom. Make sure that you look at table 23-1 in your textbook, which shows the APGAR scoring. There are 5 things we look at when we're calculating our APGAR score. Those 5 are the heart rate, the respiratory effort, the muscle tone, reflex irritability, and color. And you know that you can get scored, the baby can get scored either from a 0 to a 2. So the lowest score you can get for an APGAR is a 0, and the highest score you can get is a 10. And again, we do APGAR scoring at 1 and 5 minutes after birth. And if the APGAR score is 7 or under at 5 minutes, we would go to a 10-minute APGAR score. And usually you'll see APGAR scores if we're doing a resuscitation. Every 5 minutes we're doing an APGAR score until the baby is above 7. This is figure 16-21 in your textbook. It's the birth of the head with the modified Ricken maneuver. Note control to prevent too rapid birth of the head. This is figure 16-22 in your textbook. It shows the different types of episiotomies that we could perform. You'll see the median or the midline or the mediolateral. And this is if the physician or the midwife deems that they need a little bit more room in order to deliver the fetal head. Okay, now we're going to talk about perineal trauma related to childbirth. Most acute injuries and lacerations of the perineum, vagina, uterus, and their support tissue occur during childbirth. Alternative measures for perineal management, such as application of warm compresses and gentle perineal massage and stretching, have been suggested to lessen the degree of perineal lacerations and trauma. You just need to know that some degree of damage is going to occur to the soft tissue of the birth canal and adjacent structures during every birth. The tendency to sustain lacerations varies with each woman. Typically, people or women who are having their first babies tend to have a little bit more tissue damage than multiparous women. Now, when we're talking about perineal lacerations, they usually occur as the fetal head is being born, and the extent of the laceration is going to be defined like this. So you'll hear first degree, second degree, third degree, and fourth degree lacerations. So a first degree laceration is a laceration that extends through the skin and structures of the superficial to muscles. A secondary degree is a laceration that extends through the muscle of the perineal body. A third degree laceration, it continues through the anal sphincter muscle. And a fourth degree, which is the worst one to have, is a laceration that also involves the anterior rectal wall. That means, as we used to say, they tear from the rooter to the tutor. So this is a fourth degree. You have to be really careful because you don't want to sew the urethra shut sometimes. I've seen that done. Or they could have a fistula. So if the physician is doing a fourth degree laceration repair, they may ask the nurse to insert a Foley catheter. And this is really going to test your nursing skills because with a fourth degree laceration, it kind of, even after the baby's born, the vagina looks like hamburger meat. So trying to find a urethra it can be very daunting sometimes. But typically, if they have a really bad laceration, we may put in a Foley catheter so that the physician doesn't sew the urethra shut. And after a fourth degree laceration repair, the physician should definitely do a bimanual exam where they put one finger in the rectum, one finger in the vagina to make sure that there's no fistulas or openings between the vagina and the rectum to make sure that they repaired the laceration correctly. Your vaginal and urethral lacerations, they often occur in conjunction with perineal lacerations. The vaginal lacerations tend to extend up the lateral walls, or you'll hear the sulci, and if deep enough, involve the levator antemuscle. Additional injury may occur high in the vaginal vault near the level of the ischial spines. Vaginal vault lacerations are often circular and may result from the use of forceps to rotate the fetal head, or rapid fetal descent, or a precipitous birth where the babies kind of just shoot down the vaginal canal. Cervical injuries occur when the cervix retracts over the advancing fetal head. They occur at the lateral angles of the external os. Most lacerations are shallow and bleeding is minimal. However, you can have larger lacerations and they may extend to the vaginal vault or beyond it into the lower uterine segment. Serious bleeding may occur, and sometimes, depending on the type of cervical laceration, it may have to be repaired in the operating room. Now, the one way you can tell, if the way that we kind of tell if there may be a cervical laceration, is if you have continued bleeding, excessive bleeding, but you have a firm uterus. So if the uterus is firm but the mom is still having an excessive amount of bleeding, we start thinking maybe she has a cervical laceration, or she may have a high sulcus vaginal laceration. So that's one of your telltale signs that if you have a nice contracted firm uterus but your mom is still having a steady trickle or gushing of blood through her vagina, we have to start thinking maybe there's either a cervical laceration or she may have a high sulcus vaginal laceration. All right, an episiotomy is an incision made in the perineum to enlarge the vaginal outlet. It is performed more commonly in the United States and Canada. The sideline position for birth used routinely in Europe causes less tension on the perineum, making possible a gradual stretching of the perineum with fewer indications for episiotomies. And like I said before, we can do a midline or a mediolateral, and then the choice of performing an episiotomy is typically up to the physician or the midwife. But the routine use has declined. So what you're seeing now is you'll see like a lot of perineal massage, and it's still kind of controversial because some people think that excessive perineal massage enables the mom to actually have more lacerations. So it's really up to the practitioner, and then the perinatal nurse. You can tell when you're massaging the tissue if the tissue is strong or if it's going to be weak and tear apart. So it comes with time and practice. Now we're going to go into the third stage of labor, which is delivery of the placenta. And this is figure 16-23 in your textbook, the third stage of labor. And then this is showing the placenta, picture A. The placenta begins to separate in the central portion, accompanied by retroplacental bleeding. The uterus changes from a discoid to a globular shape. Then in picture B, the placenta completes separation and enters the lower uterine segment. The uterus has a globular shape. Then C, the placenta enters the vagina. The cord is seen to lengthen and there may be an increase in bleeding. And then D is expulsion or delivery of the placenta and completion of the third stage. The third stage of labor typically lasts from the birth of the baby until the placenta is expelled. The goals in the management of the third stage of labor are prompt separation and expulsion of the placenta, achieved in the easiest, safest manner. The third stage is typically the shortest stage of labor. The placenta is almost always expelled within 15 minutes. However, we do give up until 30 minutes for the placenta to be delivered. Uh, Placental separation and expulsion. Uh, the four different signs that you can tell that the placenta is ready to detach. We talked about that earlier. But typically, you'll have a change in the shape of the uterus. It would take on a more globular shape. There may be a sudden gush of dark blood from the introitus, apparent lengthening of the cord. The fundus will usually rise in the uterus, and then the mom or the woman may have a feeling of vaginal fullness, and she'll say, "It feels like I need to push." And usually that's the placenta sitting in the vaginal area. Now, after the placenta is delivered, the healthcare provider should examine for intactness to ensure that every piece or all the portions of the placenta are delivered and that none remain in the uterine cavity. This is figure 16-24 in your textbook. This is the examination of the placenta, and this is the dirty Duncan side or the maternal side. This is the side that was attached to the uterus. Typically, after the placenta is delivered, we will administer an oxytocic or oxytocin, which helps stimulate the uterus to contract, thereby helping to prevent hemorrhage. Um, Typically, excessive blood loss in a vaginal delivery. A normal EBL is 500 mLs. Anything over 500 is considered excessive blood loss. You definitely want to manage the mom's vital signs. Typically, once the placenta is delivered, we take the mom's vital signs every 15 minutes for an hour. During this stage, we're definitely making sure that her bleeding is not excessive, that she's not having any vital sign changes that are indicative of hypovolemic shock. Another thing that we're doing while we're doing the vitals every 15 minutes, we're also making sure that her bleeding is not excessive. So not only are you doing vital signs every 15 minutes after the placenta is delivered, but you're actually looking at her perineum and looking at her bleeding to assess the amount of bleeding that she's having. Care of the placenta after delivery. Um, there are some cultural traditions. I know when I was in Hawaii, it was my first time that a family asked if they could take their placenta home. And me being, a nurse from Florida, I'm like, oh, we don't do that. We send it to the incinerator and burn it. And so I went to my chargers and I'm like, they're asking to take their placenta home. I was like, it just took me by shock. And she's like, oh, yeah, we do that here. I'm like, really? I'm like, I've never had anyone ask for their placenta. But in Hawaii, if the mom wanted to take their placenta home, we had to do tests. They had to be HIV negative and they had to be Hep C negative. And if so, we would put it in the freezer. And when they got ready to be discharged, they would ask for it and we would take it to them. Like I said, here in Florida, I've never had anyone ask to keep their placenta. Okay, the fourth stage of labor is the first 1 to 2 hours after birth. It is a crucial time for the mother and newborn. Both are not only recovering from the physical process of birth, but are also becoming acquainted with one another and additional family members. During this time, maternal organs undergo their initial readjustment to the non pregnant state, and the functions of body systems begin to stabilize. In most hospitals, the mother remains in the labor and birth area during this recovery time. So typically, after they deliver, We give them an hour or two of recovery time, and if everything is stable, if they have a postpartum unit, we would transfer the mom to the postpartum unit. Nowadays, many hospitals have what we call rooming in. So when we take the mom over to postpartum, the baby and the mom goes together as a mom baby couplet. Some hospitals still will have it where you take the baby to the newborn nursery, but more and more nowadays we are starting to do the coupling or the rooming in, where the mom and the baby stay together throughout the entire time, unless there's an issue where the baby needs to go to the high risk nursery. During the fourth stage of labor, one of the most dangerous complications is hemorrhage. So, like I said, we are assessing every 15 minutes the amount of blood that the mom is losing, along with her vital signs, to make sure that she's not becoming hypovolemic. Post anesthesia recovery. The woman who has given birth by cesarean or received regional anesthesia for a vaginal birth requires special attention during the recovery period. Obstetric recovery areas are held to the same standard of care that would be expected of any other post anesthesia recovery unit. Some units will actually have a PACU, and then you have other units where the mom will recover in the room where she was at before her surgery. Care of the new mother, restriction of food and fluid intake, and the loss of fluids during labor cause many women to be very hungry and thirsty soon after birth. So, in the absence of complication, we can offer women food. Typically, I tell the moms we make them wait for an hour after delivery of the placenta, just to make sure that everything's going okay, that she's not hemorrhaging, that we don't have to take her back to the OR for emergency type of situation. So most new moms, typically after an hour after delivery of the placenta, we offer the moms juice or food or something like that, because they are tired and they are usually hungry, and one of the first questions they ask is, when can I eat? All right, care of the family. Most parents enjoy being able to handle, hold, explore, and examine the baby immediately after birth. Both parents can help with the thorough drying of the infant. Usually the infant is wrapped in a receiving blanket and given to the mother or father to hold. If skin to skin contact is desired, we place the unwrapped infant on the mom's chest and then cover the babies with the warm blanket. Typically, we are going to put a hat on the baby's head to prevent heat loss. This is the time we can encourage breastfeeding and encourage maternal infant bonding. Okay, here's the question. The nurse would assist the laboring woman into a hands and knees position when A. The occiput of the fetus is in a posterior position. B. The fetus is at or above the ischial spines. C. The fetus is in a vertex presentation. Or D. The membranes have ruptured. The correct answer is A. The occiput of the fetus is in a posterior position, because remember I said the moms can deliver in an OP or occiput posterior position, but it just causes them to have a longer push time. So the best position, or the most effective position for a vaginal delivery, is the OA or occiput anterior position. This ends the audio lecture for Chapter 16, Nursing Care of the Family During Labor and Birth. Thank you.